Good afternoon, everyone, and thank you, Dr. Banshi sir, for inviting me and all the dignitaries of here. Thank you, chairpersons, for that kind introduction. So, I'll be speaking on should mental health screening be a standard component of diabetes care. So, I want you to look at the second image. It's very important. Look at it carefully. I will talk about it later in the lecture. So, my question is if we check HbA1c regularly, why don't we screen or check on mental health? We all know having diabetes can take a toll with different aspects of self management, often feeling overwhelmed. The responsibility of managing diabetes mostly lies with the patient, and it's a lifelong condition. And people with different types of diabetes have distinctive psychological needs. So, if you see in this picture, patients with type 1 diabetes, they are three times more susceptible to have depression, whereas people with type 2 diabetes are two times more susceptible to have depression. Coming to generalized disorder, as my previous speakers have spoken, both of them have three times more risk of having a generalized anxiety disorder. And coming to eating disorders, in both the groups, eating disorder is prevalent more, especially in women. Bulimia is more common. And then cognitive decline. We all know that with high sugars, there is impairment in the brain function, and it's a bidirectional relationship. So one affects the other. Impact on quality of life. We all know that the personal cause of those living with type 2 diabetes are many. It can have an impact on relationship, as Dr. Vinay mentioned, and on social life, on working, and on overall psychological well-being, as well as interpersonal relationships. There is this constant monitoring which is required, a healthy diet pattern which everyone has to follow, those living with diabetes. So all of these adds a strain on the patient. And the opposite may also be true. Feeling depressed or anxious can lead to poor control of diabetes. So there has been studies which have been reviewed by Frank Snoik and his colleagues in the Lancet. And for those who don't know, Dr. Frank Snoik, he's a leading mental health specialist, and there are various articles written by him with respect to diabetes and mental health. Coming to our Indian data, Dr. Zargar sir has also published studies on depression and diabetes, where those who have depression have an increased risk and poor control of diabetes, and the vice versa is also true. So there is this vicious cycle of depression we see in those living with diabetes. It tends to aggravate the depressive symptoms. So, diabetes mellitus and affective disorders. So, as I mentioned before, with depression, type 2 diabetes, 28% of the global population has depression, and with type 1 diabetes, 12% of the non-diabetic population has depression. Coming to anxiety disorder, 14% present with generalized anxiety disorder, and 40% for anxiety symptoms. Coming with eating disorder, most prevalent now in the adolescent group. They tend to binge eat, and there is decrease in physical activity, more screen time. So all of these add to that pattern. So it is very important that we distinguish diabetes distress from depression, as Dr. Vinay mentioned. So in diabetes distress, it's more of a affective disorder where the patient tends to have this feeling of worthlessness. Again, with depression, yes, those symptoms are also present, but in depression, it is multiplied. There is anhedonia, there is lack of motivation, whereas in diabetes distress, it is more of this constant need of feeling that I am a burden and I have to. So it's that self-negative thought, and those patterns are there. So, as I mentioned, there is a close relationship between diabetes mellitus and psychological distress. The need of constant monitoring, medication adherence, all of these they add up to the distress present, and that can lead to poor compliance also. And as I mentioned, poor sugar control can lead to decline in cognitive function and to affective disorders. So, what does the literature say? There is a dearth of information and a dearth of literature present out there. So, living with diabetes, it does not often occur in a vacuum, considering mental health. The family at large is affected. Dr. Vinay mentioned about his patient experience where the wife was consulting him whether she should marry the person or not. And so, yeah, it does not often occur in a vacuum. We have to consider the whole family setup as well. Combining diabetes and mental health care. This again is a very important paper. And coming to NIMHANS, coming to our own data. So NIMHANS had published data stating that those living with type 2 diabetes, they have an increased risk of depressive disorders. Those living with type 1 diabetes also have an increased risk of depressive disorders. However, in our country, there is no structured protocol as to what to follow, as compared to the Westerns, where once a year a screening is mandatory. So, psychological need in people with diabetes, there are 5 levels. So, level one is general difficulties coping with diabetes, which is common to most of the people receiving the diabetes diagnosis. Level two is greater difficulty with coping than level one, significant but uncomplicated anxiety and or depression leading to poor self care. Level 3 is psychological problems related to diabetes like anxiety, depression, diabetes distress, phobias, needle phobia, phobia of hypoglycemia. We tend to counsel our patients on hypoglycemia, which we must do as a part of our counseling. But the patient usually takes that in a negative way most of the time, and that fear is always there in the patient that suppose if he or she lands up in a hypoglycemia, it can be life threatening. Level 4 is significant difficulties coping and self caring in context of multiple complexities, complex traumas, societal difficulties. And level 5 is severe mental illness, dementia, and or eating disorder. So, coming to the Indian context, the cultural beliefs and the barriers. So, mental health struggle in India goes beyond biology. Cultural, social, and economic factors are very important. First is denial and stigma. It's just stress, not diabetes. So, there is this fear of rejection because of n number of problems. Coming from employment to marriage proposals, especially when it comes to women. Then it is in our country, if nothing works, we all tend to blame it on black magic. किसी ने जादू कर दिया, नहीं हो रही थी. So that first picture which I showed you of the lady, she was tied up with the chain. So we will overlook all of those aspects, but we will not go deep into seeing if the patient is struggling with mental health problem. Why? Because say for example, if someone is hit by a car. What is the first thing we see and we tell the patient? We don't tell that patient like, come on, you can do it. Why? Because we can see that the person is bleeding. Whereas in mental health, we don't tend to see that the patient is suffering because that visual cue is not present. However, if we counsel the patient, if we dig a little deeper, there are subtle signs with the patient leaves here and there. So it is very important that we spend a little more time on counseling. Just 2 minutes more. So, ADA and WHO annual screening for depression and distress is mandatory over there. India, there is no official recommendations in routine diabetes care. There is limited awareness even among doctors. Short consultation times. Diabetologists tend to focus on the sugars, not the moods. Social stigma, as I mentioned, seeking mental health care is mostly equivalent to stating that you're weak, you cannot keep up with the task at hand and all the responsibilities that you are facing, and there are no trained professional in most of the diabetes clinics. So the evidence why it matters: depression, it increases HbA1c by 0.5 to 1.5%. This is a paper by Anderson et al. Patients with untreated depression have a higher risk of complications and mortality. Therapy and lifestyle changes, we know, adds to better glucose control and adherence. Diabetes distress, I won't speak about much. Dr. Vinay Dandanya sir has already spoken about it. So, call to action, the way forward for India. What we need to do is have a routine mental health screening in diabetes clinics. Hospitals, we should hire psychologists for the diabetes team, especially. Policymakers include mental health in diabetes care guidelines. With the pharmas and the NGOs, make mental health. non-taboo topic, break that stigma. And then we have many simple tools like the PHQ-9 questionnaire for depression, the GAD-7 questionnaire for anxiety, and the diabetes distress scale. So when the patients are sitting in the consulting room, we can just hand out these papers as Dr. Shifali ma'am does. So it is we get a thorough overview of the patient. And then train diabetes educators to recognize the symptoms. Telemedicine is available now, AI powered screening is there. And then, of course, we have to be culturally sensitive, address the stigma, involve the family in the education. So, conclusion, if we can test HbA1c in every visit, we should also test how our patient feels. Screening should be mandatory and not an option. The relationship between diabetes and psychological disorders is multifactorial. Emotional and psychological needs of the patients with diabetes are often compromised when personal efforts to meet these challenges fail to succeed. Addressing psychological distress is important for optimal diabetes care, and there is a need for discovering treatment for mental health in diabetics. So, my concluding remark, blood sugars isn't the only thing that fluctuates, emotions do too, and that's okay. Strength is in finding the balance. Thank you.